Please allow me to introduce the next speaker, Dr. Jan Landa, a respected authority on the subject of women's health, hormones, and functional and regenerative medicine. She's the author of the Sex Drive Solution for Women, co-written with Virginia Hopkins and created of the Rewire Desire and 3 Weeks to Endless Energy programs. She has helped thousands of women regain their energy and drive. Welcome, Dr. Jan Landa.
Thank you. Thank you. So when I was 28 years old, and I was only married 3 years, I was a chief resident in OBGYN, I completely lost my sex drive. Absolutely, completely, and totally. Now, I know we are here to talk about older women, but I'm just kind of introducing you to where I got this passion for passion, I call it, because losing your sex drive at 28 years old does not seem normal, especially when you're in your last year of OBGYN residency, and nobody has taught you anything that you can do about it. Literally, in 4 years of residency, they barely mentioned it. I see some people nodding. We didn't get that training. And that sent me on a mission that has lasted until today, many, many years later, to help myself with my own sex drive sexual issues, and of course, thousands of patients, and of course try to impart that knowledge to doctors. And I'm so privileged to be here to speak with you, to talk to you about this, so that hopefully you can help your patients and not just tell them what a lot of doctors do. As you know, they say, well, it's just the way it is. You got to live with it. You know, that is not the way it is, and we don't want that to be the way it is. So let's jump into this so we can cover it pretty thoroughly. So I want to talk about the normal consequences of aging on women's sexual health. I want to define the mechanisms of sexual dysfunction in women, in older women specifically in this talk, and talk about some of the hormonal treatments that may help older women with challenges to their sexual function. So disclosures. So don't ask, don't tell. You know, like I said, I wasn't trained to fix this problem. And so when you don't know what to do to fix the problem, is that probably the very last thing that you're going to want to ask a patient about? Because you don't want them to go, oh yeah, I have that problem. And you're going to go like, yeah, I don't know what to do to help you. So of course you're not going to ask. Don't ask, don't tell, right? But multiple studies, recent studies, have shown that most women are having this problem, and we'll talk about the prevalence in a minute, but most women are having this problem, and they want you to ask the question. So my goal and mission is that after you've sat here and attended today, that you will ask the question, that you will ask women, how is your sex life? How is your sexual satisfaction? How about your orgasms? How about your sensitivity? How about your drive? All of those questions should be fair game, right? And if we're not comfortable with those questions, how likely do you think it's going to be that your patient is going to be comfortable asking that question? So today, my goal is, let's get comfortable with this question. And let's get comfortable having a few answers in our back pocket to help these women out. So this graph that I'm presenting to you in the middle, or table, I should say, is from the Preside study. And that was done in the late 90s. And that was actually pretty groundbreaking and shocking, because that was when we first realized that about 44% of all women, any age, had sexual problems of some kind during their lifetime. Nobody realized that it was that prevalent because nobody had asked the question before. So like I said, when I was 28 years old, I was having all these problems. Nobody had taught me anything to do about it. Well, you know what? That was the late 90s. And the late 90s was when women's sexual health research really just even started to happen. Nobody was looking at those questions before. So now, thankfully, we have lots of studies. And one of the more recent ones in 2015 showed that impaired sexual function, defined as low sexual desire or arousal, which we'll talk about the difference in a minute, difficulty reaching orgasms and sexual pain, so those are the main classifications of women's sexual disorders, were reported by 58% of women in that past year. Yeah, wow, right? I see some of you going like, whoa. Higher prevalence than depression, 58%. So it's crazy that we're not asking this question. And it's crazy that we're not addressing this in a bigger, more global way. So the classifications. You know, the classifications are a bit controversial in the past couple of years. They're classified in the DSM, and the DSM-5 came out rather recently, and there was a big hullabaloo from the DSM-4 to the DSM-5. They made some significant changes, which many people in the sexual health world were very much against. So what I really want to highlight for you here is that the most common, if I go back to that, I don't know how to go back there. If I go back to this, you'll see that the first column is desire. That's the most common issue. Second most is arousal, then orgasm, and then sexual pain disorders would be the fourth one. So when we look at this here, when we talk about HSDD, hypoactive sexual desire disorder, what we are talking about when we talk about desire is up here. Do I want to have sex? Do I desire sex? When I talk about arousal, I'm talking about below the belt. I'm talking about the responsiveness. Do I have sensitivity? Do I have lubrication? Do I have engorgement? Those things are arousal. Now, of course, many times it's a mixed picture, right? I have a desire issue and an arousal issue. But many, many studies have looked at this issue, and what we've found is women with hypoactive sexual desire disorder, the brain one, the one where I don't want to have sex, very frequently will have very adequate arousal. They've done studies showing that you show these women pornographic material, they do get lubricated, they do get engorgement, but they have what they call a lack of interoceptive awareness. That means a lack of bodily sensations. So in other words, their brain does not detect what's going on down here, even though they're having the response that you want them to have, which is the main reason why when sildenafil came out, when PDE5 inhibitors came along, they said, oh great, we got this pill for men, let's give it to women too. Unfortunately, it doesn't work for the desire issue. It only works for the arousal issue. So that doesn't mean it's not valuable, it just doesn't work in every population. So that's why I feel so passionate about you knowing what the issue is. Does she not want to have sex, or is she not having arousal, or is she having both of those problems? And then, of course, there's orgasmic disorders and sexual pain disorders, and, you know, I'd need to do a course for 1,000,000 weeks. We did a sexual health certificate course, and that was 50 hours of material. So I've only got 45 minutes, so I'm going to have to keep this kind of like squished in, but you can tell how passionate I am about this topic and could probably talk to you for many hours on all of these different issues. So this overwhelming, messy slide is to highlight the perspective of there is usually no smoking gun. There is not usually one cause to a woman's sexual disorders, to a woman's sexual problems. It's usually a lot more than one. It could be her relationship, it could be her hormones, it could be her stress levels, and usually it's a combination of these things. So what are the causes? What do you need to look at? What are the classification systems? So hormonal, I would say, is number one, and especially in the older woman, and we're going to talk about lots of different ways that we can solve that problem for them. But of course, bless you, there's neurogenic changes, there's psychogenic. So the psychogenic in some studies has been shown, especially in desire disorder, to be probably the number one component. So there was one study where they showed a woman's sexual health was not really related to the number of orgasms she had, her sexual satisfaction. It was actually much more related to her psychological health. If she had depression or anxiety, sex is pretty much off the table for a lot of women who have depression and anxiety. But the other one, that was the second most common factor, relationship issues. And I see a lot of you nodding, because if you do this kind of work, you know that there are a lot of things that are just right below the surface. So along with relationship, I say the other R that goes along with that is resentment. As women, we are nurturers. We tend to take care of everybody and everything, probably a lot more than our own self-care, than we take care of ourselves. And even the men in the room, when we're healthcare providers, we tend to be nurturers to the nth degree, right? So we're taking care of everybody else before we take care of ourselves. And when we do that, when self-care is low, resentment tends to be high. And a lot of these women think they have a hormonal problem, and then when you talk to them a little bit more about everything that's going on, they are so overwhelmed and stressed, and a big part of the reason they're resenting in their relationship. There's resentment in their relationship, and it's because they're running around doing too much and not taking enough care for themselves. So anyway, I'm derailing a little bit, but just to tell you that psychological issues, you cannot underestimate the power of the psychological issues. So, don't figure that everything's just going to be a slam dunk about hormone. You're going to give them hormones, it's going to be a slam dunk. Landa said, use this, use that, it's going to be great. On occasion, you will give them everything, and everything will be functionally fine. But if that relationship's not fine, you've got bigger issues. So, of course, vasculogenic, which we'll go over a little bit, and medications and genetics. So, we talked about the incidence of sexual dysfunction in women in general is about 42 to 44%, depending on studies. You'll find different studies who say different things. But in menopause, it goes all the way up to 82%. So it is the norm, right? And if we are not talking about this problem, which we can fix so easily, you will see, we are missing the boat. So these women have a decline in all areas of sexual response, in their excitement, in their interest, in their function, their frequency. And one of the things I really the reason I bolded low satisfaction with partner down there is because it is so crucial. One of the things we say in sexual medicine is if you want to treat a person's sexual response, male or female, treat the partner. If you get a partner functioning better. So a lot of women will say, well, my husband can't really get an erection. And between her dry vagina and his lack of an erection, things are not going well at all. But sometimes if you restore his erection, and then of course you re-moisturize and reinvigorate her vagina, you're in business before long. And surgical menopause, of course, that is the worst type of menopause there is, because when you remove a woman's ovaries, one of the things to keep in mind, a little nuance that a lot of people may not realize, is that after menopause, yes, estrogen and progesterone go way down, but one of the things that's interesting is we will make testosterone well into our 60s, 70s, and beyond. And so when you take out a woman's ovaries, you take out that source of testosterone. And so that surgical menopause is much more debilitating for women than regular natural menopause. And you really need to consider the testosterone component in those situations and scenarios. All right, so meds. I'm very passionate about the first one, hormonal contraception, especially oral contraception particularly, because when I was 28 years old, what do you think I was taking? OCPs, right? And so what do OCPs do? What does oral estrogen do? What does it raise? Sex hormone binding globulin, of course. And what does sex hormone binding globulin bind up? So what did it lower for me? My free testosterone, of course. And one of the most fascinating things to me is, what age do you think our testosterone, from what age to what age do you think our testosterone takes its biggest drop, its biggest nosedive in our whole lives? Between the ages of, what would be our high age? Puberty, okay, close enough, 18, to when would you see the biggest drop, do you think? 34, I heard somebody say it. Maybe you've heard me talk before. 18 to 30, or you've read that statistic. 18 to 34 years old is when women have the biggest drop in their total testosterone. So you're on OCPs, and you have this big drop in total testosterone, and then your free testosterone goes down. That's a pretty bad recipe for disaster. And then, not to mention, of course, stress, I would say, is one of the biggest sex killers, women with desire disorders. Stress is a huge part of that. And OCPs also kill the HPA axis, the hypothalamic pituitary adrenal axis. OCPs make us less resilient to stress. So between those two things, that was the biggest thing that was going on with me. But I didn't know that. It took me years to go figure this out. Anyway, so I'm not saying we can't use contraception. I'm just saying there are certain women who are more sensitive to it than others. There are other drugs as well. Of course, cholesterol-lowering drugs. Why do cholesterol-lowering drugs pose a problem sometimes? What can they lower? They can lower cholesterol, sure. But what is cholesterol the backbone of? Hormones, particularly testosterone, right? So, I hate it when I see my patients come in with a total cholesterol of 110 and their cardiologist thinks, yes, slam dunk. I'm like, no. Where do we need cholesterol in our bodies? Brain, right? We can't think without cholesterol, and we sure as heck can't have sexual satisfaction without our cholesterol. So many other drugs as well. Vasculogenic. So this is really, really important for both male and female sexual dysfunction. We need to consider this. So a big part of that whole arousal piece, right, is blood flow. It's what's going on in the vascular endothelium. And if we have vascular endothelial damage, where is it going to show up first? It's going to show up in the genitalia because these vessels are only 1 to 2 millimeters, as compared to your cardiovascular vessels, or your cardiac vessels rather, are like 3 to 5 millimeters, 3 to 4, and then up here the carotid's 5 to 7. So this atherosclerotic disease, this endothelial dysfunction, is moving up the body, and of course we have endothelium in our brain as well. So whatever we can do to improve the endothelium will improve sexual function, but vice versa. We always have to think about arousal disorders, male or female, so erectile dysfunction in men, and then sometimes lack of sensitivity, let's say in a diabetic or something in a woman, will possibly be a harbinger of cardiovascular disease. It may be your earliest sign. So I think of the penis as a barometer for cardiovascular disease and cardiac health. So just keep that in mind as we talk about all of this. And the importance of lifestyle therapies. So studies have shown, there was one particular study they did in diabetics, put them on a Mediterranean diet for 2 years and showed that their sexual function index scores went way up. So you can really have an intervention, just a dietary intervention on top of everything else that we're going to do. So dyspareunia. Dyspareunia is pain in the vagina, sexual pain, right? There's two sort of broad classes. Vaginismus is one of them. So vaginismus is the involuntary contraction of the vaginal muscles. You realize the vagina is a tube of muscles, basically. And if a woman has sexual pain, let's say from atrophy in menopause, she's going to have pain when she has sex, right? So what is she going to do? She's going to obviously she's going to contract those muscles. Unfortunately, some women get into a cycle where they can't relax those muscles, and that's known as vaginismus. So that's something to keep in mind. And then vaginal burning can be just decreased lubrication, can be menopause, and it can be other things too, antihistamines, and all kinds of other things. So a good history is important, a good exam is important. These are some of the things that you're going to look for. When you check for vaginismus, if you want to check for this involuntary tightening, you put the 2 fingers in the vagina and you check toward the posterior right, left, center, and you'll feel the band of muscle contracted. That's how you can usually tell. And if you push in that area and you say to her, is this where it hurts when you have sex? She'll say, yep. So you identify that pretty quickly. And you can treat that. There's a great website called vaginismus.com, and it has tons of information for you as to how to treat it. But lubrication, vaginal dilators, progressive relaxation are all parts of it. And even PT physical therapists who do pelvic floor physical therapy can really help these women a lot. So for vulvar disorders, of course, there's vestibulodynia, and we could go on and on about that for hours, but it's a little outside of the scope. I was telling you about vaginismus.com already. But what I really want to focus on is GSM, the genitourinary syndrome of menopause. Bless you. She's right in front of me. I saw it coming. So it's a comprehensive term encompassing VVA is basically what we've been referring to it as, vulvar and vaginal atrophy. There's genital symptoms of dryness, burning, irritation. There's sexual symptoms, lack of lubrication, the discomfort that comes along with sex, impaired function, so decreased sensitivity, decreased ability to have orgasm, and then urinary symptoms as well. So you may or may not realize the urethra has plenty of estrogen receptors, and our urinary health changes in menopause as well as our genital health. So VVA characteristics. There's, of course, thinning of the vaginal tissue. So this is one of the things about GSM and menopause and everything that amazes me. We talk all about menopause, right? You hear about it in the major media. You see women have hot flashes. So women know, I'm going to have hot flashes. I might not be able to sleep. I might want to bite people's heads off. But the thing that they don't know is that their vagina is just going to shrink like a raisin. And nobody talks about that. And it's devastating for a lot of women. They say, I can't even understand what happened. I can't fit them inside anymore. It just doesn't go. It doesn't fit. And women, for some reason, we talk about all kinds of things, right? But we don't talk about this anywhere near enough. So women don't know there are solutions. There's literally, though, thinning of the tissue, there's narrowing, there's shortening, there's decreased vaginal blood flow and decreased vaginal blood vessels. We have a decrease in the blood flow altogether. And of course, that causes vaginal pain, dryness, itching, burning, irritation, even bleeding, tearing, things like that, and of course, pain with urination. And this is unlikely to resolve without any medical intervention. It is likely to get worse and worse. And some women, even if they're not sexually active, they just can't walk without, feeling their lips rubbed together and have horrible irritation. So we need to do something for this. We can't just leave this alone. So there's, additional anatomic changes, reduced collagen content. We know we have that in our face skin, but we have that down there too. And the vaginal lining can be reduced to even just a few cell layers. It's amazing. The septum between the rectum and the vagina can become so thin that it's barely there. Some of you who've done examinations, you know what I'm talking about in menopausal women. The labia minora thin, the introitus that retracts, the hymenal remnants curl up, they lose their elasticity, the rugal folds decrease, the pH increases, the urethral meatus becomes more prominent, and that can be very irritating for women. All of this is due really to reduced circulating estrogens. And this, doesn't this sound absolutely awful? I can't even fathom it. But then on top of it all, the changes to the microbiome. So we talk about the microbiome a lot in terms of the gut, right? But we need to realize that the vagina has its own microbiome. And estrogen helps keep the microbiome healthy. It helps keep the pH proper so that we have the right mix of bacteria there. And so this on the left side is a premenopausal thick vaginal epithelium, a thick layer of mucus, high estrogen levels, high lactobacillus. So one of the things that the estrogen does is it supports the pH, which supports it supports the lactobacillus, which supports the proper pH, and it all works together. The problem is, as you see in the middle column, if you can't read all these things, basically it says it's a thinner disrupted vaginal epithelium. This is a menopausal woman, a symptomatic menopausal woman. And you can see she has very little mucus layer. Her microbiome is all messed up. Her pH is all messed up. And then the one on the right is a woman on hormone replacement therapy who is asymptomatic. So you see, we can't necessarily build it back up to where a woman was premenopausally, but we can certainly do a lot to maintain her epithelium and to really help her. And even low-dose estrogen can restore that microbiome. So it's a huge problem, and no solution is being offered for the most part. 50% of women have symptomatic VVA. That's 32 million women in the US. And there is a huge lack of treatment. Most women are unaware of how this is a chronic, progressive problem that's just going to be worse and worse unless they get treatment. And then, of course, the majority of them are afraid of treatment, or they don't even know there is treatment. Only 7%, amazingly enough, are regularly using prescription VVA therapy. Isn't that shocking with the vast enormity of this problem? So 93% of women with VVA are untreated. They are needlessly suffering. And most of these women think they will never be able to comfortably have sex again. And remember I said this painful sex can lead to this vaginismus problem with this involuntary contraction of the vaginal musculature, and that can be even a longer thing that you've got to fix. And it can lead to infections, of course, BV, candidiasis, all kinds of, and then women wind up on that merry-go-round of, vaginal antibiotics, then vaginal antifungals, and then back and forth, and then they wind up with chemical vaginitis. It's a nightmare thing when it's so easy to fix. I just wanted to tell you briefly about a patient of mine. Her name is Jane. She came to my office at 60 years old, and really her main problem, she's a mental health nurse practitioner, and her main problem that she came to me about was her brain. She was worried that she couldn't remember details about her patients, details about drug therapy, and she wanted to be sharp on the job. But of course, I did my job. I asked, what's going on with sex? She said, yeah, we haven't had sex in 7 years. Yeah. It's been so painful. And Joe is just a really understanding guy, so I'm really lucky. But no sex. And no plan to have sex. This was not even a question on her mind. This was not a concern she wanted to raise with me. So the most wonderful and amazing thing I have to say about Jane now is that I've been treating her for 5 years. Her and her husband are happy little bunnies now. They are very frequently intimate with one another, and they are truly, she is retiring at the end of this year, so at the end of this month. Congratulations, Jane. And she cannot wait for the next chapter of her life with her husband, because they are more intimate than they have really ever been before, because they had had this severe lack of sex in their lives and that lack of intimacy that comes with that. And now that they're back together and they never thought it could even be possible, they're just taking full advantage. So this is something we need to do for our patients. And she said, when you told me on the first day that could be changed, I didn't even believe you. And she's a nurse practitioner. I mean, this is a very educated woman in the medical field, you know? It's like amazing. So I want you to be a hero, because I will tell you, sometimes it is such a slam dunk to use localized estrogen therapy. It changed her life, it changed her marriage, and I just really want you to get this message that you can so easily be somebody's hero. And doesn't that feel freaking great? Don't I love every time Jane comes back to me for follow-up and tells me, Dr. Landa, you can't imagine how good it is. Joe is so happy. Joe doesn't know me, but Joe loves me. So estrogen therapies, of course, they play a vital role. This isn't the greatest, most clear picture of it, but on the left-hand side is an atrophic vagina, on the right-hand side is a re-estrogenized vagina. Estrogen therapy will literally plump up the tissue. You lose that plumpness when you go through menopause, and the estrogen therapy will literally just plump it back up. It will improve the pH, and it will improve the atrophy. So let's talk about how to do it. So this picture really makes me laugh. So this is to remind you that the vagina is not made of cement. That is literally a cement vagina that exists in Berlin. And this was a student playing a prank who got stuck in the cement vagina and had to be removed by firefighters. Yeah, it kind of serves him right? So one of the things I want you to know is, depending on dose and depending on delivery, there's multiple things that it depends on, but there are studies that show that certain vaginal estrogens are very much systemic estrogens. But then there are other studies that show lower doses and different delivery methods that the estrogen is barely systemic at all. So there are many oncologists that will allow you to treat breast cancer survivors with local estrogen therapy, because there are several that have been proven to have very little increase in systemic levels, very little or even none. So lack of compliance with VVA therapy. So one of the reasons that only 7% of the women were on the VVA therapies in that study that we read earlier, it wasn't that more women didn't get prescriptions. It was at least double the number of women who did get prescriptions, but a lot of them don't comply. Why? The typical thing that when I was an OBGYN and when I was taught to prescribe this type of therapy, I was taught to prescribe very messy vaginal creams. You know, kind of like you would use to treat like a yeast infection. It's like a whole big tube full of cream. It's nasty. It's like, are you kidding me? You want me to put that? Yeah? And then it just drips out all over your panties, you know, and it's not even getting to where it needs to go. And we'll talk about that in a moment. But believe it or not, deep inside the vagina, not where the main problem lies. And we'll talk about that. But the messiness is one of the biggest reasons that women will not stick with the therapy. So you've got to do something to get around that. So there are vaginal A2 tablets that have been around for a while. On the left-hand side, you can see that they go really deep in the vagina by the cervix. There's that blue applicator that comes with it. It's a little tablet. Anyway, the reason that I find that these don't work very well for women is that, remember that the vagina is from two different embryologic origins, right? The distal 1/3 and the upper 2/3. You remember that from embryology a million years ago? Well, it's really pertinent here. And I have a friend who's a vulvologist. He's an internationally known vulvologist. Believe it or not, that's all he does. Just the vulva, you know, it's pretty specialized. But what he says, it's not really the distal third, it's really the distal 7/8. And what we're talking about is that's the main part that's hormonally sensitive. The rest of the vagina really isn't very hormonally sensitive at all. So what good does it do me to shove creams way up there that are going to fall out of my panties anyway, or to put a tablet way up there that's going to dissolve way up there and not treat the introitus? It's the introitus that is the most hormonally sensitive. So we need to get the therapy to the introitus. So enter a new vaginal delivery system that's it's a little, I forgot how to exactly say what it is, but it's like almost like a jelly bean, if you will, but it's much softer and it dissolves. Basically, you apply it to the introitus. It's made of coconut oil and estrogen, and it melts like that. And women say that it's amazing because the therapy, number one, it's very efficacious. It works quicker than these other methods because it's going right where it needs to be delivered. And second, it's not messy. It just dissolves right there and it's done. So that seems to be a very elegant method as well. But if you're into being a little bit more creative, like I've always been, I do a lot of what I call my vaginal cocktails. So I do compounded vaginal estrogen creams, and I sometimes compound some testosterone into the cream, some DHEA into the cream. So this is my little protocol. A lot of times I'll start with E3 estriol alone because there are many great studies that show that the estriol is great for overcoming atrophy, for resetting the pH. But sometimes I'll also add some estradiol in there, and sometimes I'll add some testosterone, some DHEA. It sort of depends on the patient and what I think they're going to need. And if the patient's main complaint, if they have low hormones kind of globally, but their main complaint is vaginal, I may just decide to deliver all her hormones vaginally, including the progesterone, throw it in there as well. And all she has to do is one vaginal cream a day, and she gets all her hormones. But that's not every woman. This is individualized, customized, personalized medicine that we're dealing with, right? So you've got to assess what you think your patient would like. And I combine them all, this is very important, I say here into a 0.5 to 1 ml dose. I sometimes even go down to 1/4 of an ml. So when I was talking about those big, messy tubes of cream, I mean, that's like at least an ml, if not like 2-3 mLs. I mean, they want you to put on a ton of this stuff, which is why it's so messy and gross and nobody wants to use it. 1/4 of an ml for a lot of women will be enough. And so what I tell them to do, so many of the compounding pharmacies, if there's compounding pharmacies in the room, you might be horrified to know that I tell my patients that vaginal applicator that the cream comes with, just throw it out. I tell them to take 1/4 of an ml onto their finger. So sometimes I'll use that clicker thing, it delivers 1/4 of an ml. Put 1/4 of an ml on your finger, put that finger inside only to about the first knuckle, and then rub it around inside for about 30 seconds, and then apply another 1/4 of an ml, and take that for about 30 seconds, rub it into the clitoris, the introitus, the labia, and just rub it in really well. So then it's not a big, messy thing. And I tell them to do this in the morning after they've done their workout, shower, pee, apply. And because of course we're always worried about transference to male partners, right? So you want to try to keep them away from their male partner for, nobody knows the exact amount of hours, that would be the optimal amount, but I try to go for at least 8 to 12, something like that. Yeah, so the estrogen ring that stays in for 3 months, some women do find that a wonderful option, and that's one of the ones that has a very low systemic level. So that's one of the ones that the oncologists actually will use a lot of times in women who've had breast cancer treatment, and because it has very little systemic rise in estrogen levels. So I do like that as an option. One of my patients is using it, and she loves it because so instead of having to apply a cream or anything every day, she loves the convenience of the ring because you only change it once every 3 months. She said it's ridiculously expensive. Maybe that's just her particular insurance, but she loves it that much that she's like, right now it's worth the money. So it can be very good. It is absolutely effective, yep. And my biggest problem with that patient actually is that no matter what other type of estrogen I've given her, she's had development of polyps and she's had postmenopausal bleeding. And this option seems to be working because she's having great relief from her dyspareunia and her dryness, but her VVA symptoms, but she's having no bleeding. And her gynecologist, that's a mutual friend of ours, is about to do an ultrasound, and so because she's only been on it for this year. And so I have very few patients on it, truly, because I do a lot more of this other stuff I've been talking about, but that can be a really appropriate option for breast cancer patients especially. Yes?